So what I'm going to talk to you today about is what I know clinically, I'm very familiar with, and I deal with this on a daily basis, and that's pressure ulcers. Pressure ulcers are a common and very frustrating occurrence, and particular to the spinal cord injured population. And what's really staggering is the incidence of pressure ulcers in this population. So that means that reported ever having a pressure ulcer, the range is from 62 to 64% and from 85 to 87%. And then the ulcer recurrence stats are even more frustrating because people report up to 80% of the time having a recurrence over their lifetime. So it's a really big problem, and if you've had a pressure ulcer, I'm actually going to ask people to put their hands up if they've experienced a pressure ulcer so far in their, so there's just one person so far. So, and so what exactly is a pressure ulcer? Well, if you think about someone that has a heart attack, what happens to the muscle that's the heart muscle that's beating, it loses oxygen supply and blood supply because there's a blockage in the coronary vessels, and within 5 minutes of that blockage, the person will start to experience chest pain, and the muscle starts to die very quickly. And so we get these symptoms of pain, the crushing chest pain, shortness of breath, etc. As the muscle starts to die, all the other organs start to fail as well. So it's that kind of an injury is caused by a blockage, and pressure ulcers are similar to that, only the mechanism is different in terms of cutting the blood supply off. And what it is localized injury to the skin or the underlying tissue, usually over a bony prominence, and it's the result of pressure in combination with shear or friction. And the cause of pressure ulcers is applied to soft tissue so that the blood flow to the soft tissue is completely or partially obstructed. And another type of force, so this is, pressure is sort of downward forces, and then we have shearing. So what that means is that your bones and your skin are being torqued against each other, and the tissues get ripped apart. The blood vessels get pulled apart as well, and you get even more injury from that force, and that's a terrible force. I'm going to just show you some really probably unappetizing and graphic pictures. There's a few in here that might not make you feel very well, so I apologize for that in advance, but I just wanted to show you the different stages of pressure ulcers. And the ones that we get really, really worried about are the ones in the greater stages. So this is a stage 1 pressure ulcer, and this is just what it is basically localized erythema, which is redness, and it's a reaction to pressure. The skin is still closed, and we have an excellent opportunity of resolving this. If we can take the pressure away or the shearing forces away from this area, oftentimes the wound will resolve without ever opening. So that's a stage 1 pressure ulcer. A stage 2 pressure ulcer is a very shallow ulcer, so it usually involves just the skin at the skin level and into the dermis. So that's the second layer underneath the skin that we see on our bodies. And these ones in non-spinal cord injured people are particularly painful because of the exposure of the nerve endings. But in the spinal cord injury population, as you know, there is no sensation, and so if this is happening, people don't know what's going on until it's almost too late. And then we get into bigger and deeper problems, and this is a stage 3 pressure ulcer, and this person's buttock is actually quite large, and it looks like it's a really big and deep problem, and it is, but it actually only extends into the fatty layer of within all the layers of our tissue and our bones and muscles, etc. And again, we have a really great opportunity to get these wounds to close really quickly if we do the right thing. And then we get to the more or the most catastrophic stage of ulcer, and that's a stage 4 pressure ulcer. And this involves destruction right down into the supporting tissues, which is our muscle, tendon, or bone. And you can see that this person is very wasted from the waist down. You can see that the fatty layer is very thin, and this person has lost a lot of their body mass, and so that the layer of subcutaneous tissue is very thin, and it's easy to see why these people can get down to tendon, muscle, or bone really quickly. And then we have this other type of wound that we, at this point, we can't stage. We know it's bad. We know it's terrible because of the dead tissue. We know it's full thickness, and we know it's going to be a stage 3 or stage 4 pressure ulcer. And both of these individuals have neurological impairment. The one in the one that is lying on her side there with the 2 ulcers, this lady had Alzheimer's disease, and I'm just using her as an example, but she didn't have the sensory feedback to let people know that there was trouble occurring, and oftentimes these folks get strapped into chairs and left for long periods of time because they're very difficult individuals to communicate with. And so some of this terrible stuff happens to people not only with spinal cord injury but other types of neurological impairment. And then these unstageable ulcers that happen on the coccyx, those are the ones that we usually see, and fortunately not at St. Michael's Hospital very often anymore, but that happens when people are first injured with their spinal cord injury, and they've been strapped on a backboard for a really long period of time. They may have had a long distance of transfer from the site of injury to the spinal cord injury center, to the trauma center, and we end up with some catastrophic wounds like that in our facility. And then there's these other things called suspected deep tissue injuries. And so the difference between this one and this one is suspicious that the skin is going to open. And if you've ever seen this before, everyone was characterizing this as the purple pressure ulcer, and nobody really knew how to categorize it. And sometimes what happens with these types of injuries is they will resolve without any further incident if we can take the pressure away and keep the person off that area. But a lot of times it goes on to full thickness injury and causes a stage 3 or 4 pressure ulcer. So the last 2 or 3 slides are the worst case scenarios for individuals. And so why do people with spinal cord injuries get pressure ulcers? And there's obvious reasons why spinal cord injuries or people with spinal cord injury are more susceptible to pressure ulcers, and that is because there is lack of sensory feedback. So if you have sensation from your waist down, you're all sitting here right now, you're constantly moving, and I can see all these heads bobbing because your legs, you cross and uncross your legs, you're leaning forward, you lean back, and what's happening is you're getting the sensory feedback to your brain that, oh my goodness, my bum is getting sore, and I need to move so that I can get that blood supply coming back to the buttock area. And that's why we give you frequent breaks, because if we made you sit here all day, well, number one, you'd fall asleep, and the second thing is that you'd leave with a pressure ulcer on your backside. So we don't want to do that. We have to make sure that we're moving all the time. But there's some really important information that we need to understand about neurological injury to the spinal cord. And we know now that spinal cord injured people have breakdown, and they have very slow healing rates despite best resources and use of modalities and dressings that seem to work really well on other types of wounds. And so one possible answer is that there's differences in the denervated skin and that are interrupting the natural wound healing cycle. So this is a very, very important slide, and it's very complicated, and there will be an exam at the end of this talk. So I want you to pay close attention to this. And I'm going to try to walk you through it without having you fall off of your chairs and go running out to the bathroom. But just remember there's an exam at the end of this course. So if we start up at the top there, we have clotting activity after wounding. This creates hypoxia in the wound bed. And this change in oxygenation signals macrophages to release growth factors to stimulate new blood vessel formation. So you actually need to have a lack of oxygen to stimulate the wound healing cascade. And the inflammation phase brings the needed cellular components to the wound space to cleanse and protect and heal. Vasodilation happens, and that's the increase of the diameter of our blood vessels beyond the baseline, and that's necessary for the inflammatory phase. This phase is characterized by a rise in the redness and the temperature around the wound as the vasodilation down to the capillary level occurs to increase the flow of blood and nutrients to the wound bed. Neutrophils and macrophages then engulf or swallow the bacteria and cleanse the wound of infection. And macrophages, again, so they're like little Pac-Men going around eating all the bad guys. They secrete biological regulators that are needed for the granulation phase to begin and the process to further steps of the wound healing cascade. And then we need availability of oxygen to the tissues. And this is known to be an important aspect of tissue viability and growth. So oxygen is needed in many of the steps of building new tissues during the wound healing cascade. And then finally, we have keratinocytes, which that's a technical term for skin cells. They're required to rebuild epithelium, and it's needed to prevent infection and to supply the metabolic demands of the tissues. So that's the normal wound healing cascade. If we move to the person with spinal cord injury, things, unfortunately, the areas on this slide don't show up in terms of the shading, but it's on your slide presentation. Almost every single step of the wound healing cascade is affected by spinal cord injury. And so, you know, we get people, I have experienced people saying, you know, this guy, he's just non-compliant and he's in his chair all day and it's his fault that he got a pressure ulcer. Well, this person in the wheelchair has the tissues have changed dramatically. And so it doesn't take much for injury to start to develop. And so one of the things that happens at the very top of the chart there is that we often put people that are immobile on anticoagulants. So we want to stop people from getting deep vein thrombosis, which is a really common complication in spinal cord injury. And the problem with that is that it actually impairs the clotting factors, so it changes our platelets. And platelets are really, really important for the initial phase of wound healing. So if we are giving people anticoagulants for whatever reason, we're going to have problems right from the get-go. We have impairments in the inflammatory response, which is limited by some of the vascular impairments. We have collagen synthesis, which is impaired by lack of amino acids and enzymes. We have collagen and extracellular matrix, which is depleted because the collagen is actually being degraded instead of built up in the non-injured insensate tissues. And this is called collagen catabolism. And what we need for pressure ulcer healing is we need the person to be flipped from a catabolic state into an anabolic state. So I'm sure you've heard of anabolic steroids, and when people are in winning gold medals, they're being tested for illicit drug use, and we hear about anabolic steroids being used to build up muscle and strength, etc. And we can't use those drugs we don't use them in our wound healing programs at this point, because the evidence for them in terms of their efficacy is questionable, and also there's a lot of complications that can happen with those. But so it's really hard to flip someone from a catabolic state to an anabolic state. And it's also been found that oxygen measurements in the skin level below the spinal cord injury are lower. And then this is compounded by the tissues when they're exposed to pressure. And so we then have decreased availability of oxygen, which impairs tissue building. And then finally, the activity of the fibroblasts and building of the extracellular matrix is impaired by decreased fibronectin, resulting in poor collagen synthesis. So you can see in this whole wound healing cascade, below that level of the spinal cord injury, we're going to have problems in every single step of that process. And so what we haven't figured out, we've figured out why, but we don't know how to fix it at this point. And so the research that now is being done through the Ontario Neurotrauma Foundation and the Rick Hansen Foundation is we're trying to answer some of those questions as to why this is happening, and is there anything that we can do to manipulate any of those phases of the wound healing to get better outcomes in terms of healing. And so this mythological creature that is I'm showing you is a good representation of that it's easy to imagine the body of this mythological figure that's half human and half animal. Although the skin both above and below the level of injury seems to be the same, they're very, very different physiologically. Was that okay? Are you ready for the test? Good. Great. So one of my jobs when I first started in my role was to try to combat the pressure ulcer problem in our organization. At St. Michael's Hospital, when our program started, we had a prevalence rate of pressure ulcers which was really embarrassing. It was 29%. So almost 1 in 3 patients in our hospital had 1 or more bed sores. And that's just not acceptable. And so when I went through my master's program, I designed a wound healing and skin ulcer prevention program that would address some of these issues. And the more I work in wound healing, the more I realize the importance of prevention of these catastrophic wounds in the first place, so that people that do get injured don't have to live with these pressure ulcers. They're living with enough stress in their lives. They do not need a bad bed sore that's going to really impact their quality of life, which has already been severely affected. So there are some times when people get bed sores and they're unavoidable. So these are some of the risk factors during the acute phase of injury. So if the person has had multiple traumatic events happen, so you've been in a car crash, multiple fractures, chest injury, head injury, etc. If you have low blood pressure when you arrive in the emergency department, your blood supply is affected. Urinary incontinence is another risk factor. If you have lung disease, specifically if you've been smoking, malnutrition, ER transfer time, as I said before, between the injury site and the emergency department can really, people can come in with the problem before we even get to them and get to resuscitate them. And then, of course, time spent away from the neurosurgery ward, especially after day 15. And then I looked up risk factors in rehabilitation, and I was looking at the evidence, and there's only ever been 2 studies completed, and there was such selection bias with them that they were discarded. So we need to do more research in terms of trying to figure out risk factors for pressure ulcer development. And then I'm sure for those that are in wheelchairs, you'll know that there are real problems with equipment access. You know, depending on the sector that you're in, if you're in home care, rehab, or in acute care, in one acute care center versus another, there may be problems with access to beds, mattresses, cushions, and wheelchairs. And another problem that I have experienced is equipment maintenance as well. So if the Roho cushion or one of the other cushions that the person is sitting on deflates and becomes broken, it's really hard to get that fixed quickly. And so the person sitting on you know, malfunctioning equipment, and the time to get it to repair could just be enough time for the person to develop the ulcer, and we often see that. For the next slide, we look for risk profiling now, and that's part of my PhD program focus. What I want to look at is does surgery for stage 3 and 4 pressure ulcers in the pelvic area, so specifically in the sitting area, which is called the ischial area, does the surgery that we perform at our hospital in conjunction with the Toronto Rehab Institute, what happens to people after the surgery? So do they get better, and do they stay better? And how long do they stay better for, or do they stay closed? And then the next question I want to know is, who's the best candidate for surgery? And I'll show you in a couple of minutes why everybody in this world that has a pressure ulcer doesn't get the surgery. We're really, really, really careful about who we select to have that surgery. Some of the lifestyle, though, risk profile risk factors for pressure ulcers involve lifestyle challenges. So we look at people that come into our country that are immigrating. We get a lot of people that have come from Afghanistan and from some of the war-torn countries. They don't know our system, they don't know how to access the resources, and they're already in trouble by the time they get to us. So the new immigrants are a real problem for us. I'm going to talk to you about smoking in a minute, and if anyone's ever come to my clinic, they know that I'm the anti-smoking Nazi, and that I will bug you and bug you and bug you and bug you until you stop smoking. I'll beat it out of you, and I'm going to tell you why it needs to be beaten out of you. So if any of you smoke, who smokes? No one's going to admit it, of course. Yeah. I will find you. I can smell it. I can smell, my sense of smell is so good. I will find you. So if you get a bit pressure ulcer, stop smoking before you even get to our clinic, because you will not receive a beating for that. So, and then of course, lower socioeconomic status has there's lots of issues with that. It's not that you don't have access, particularly to services, but some of these folks have to work really long hours because they may be only making minimum wage. They have to work 12 hours, where most of us as professionals maybe work, a 7.5-hour day. I am in the lower socioeconomic status right now, and I work 14 hours a day. And so I do understand what's going on here. And they also may have problems with insurance benefits. So there may be people that are on ODSP that have very limited income and access. And then those people actually are probably better off than the people that are working for minimum wage. They have even fewer opportunities for benefits. And then there are situations where people are living in less than optimal situations. I've seen people people come down from Northern Ontario, and I'm not saying anything bad about Northern Ontario because I'm from Northern Ontario, but I know that the system up there is not as accommodating and doesn't have the expertise that we have in some of our major centers. But we get caregiver stress, and so there was one report of a person that was left in a wheelchair who was quadriplegic for 12 hours because their caregiver got drunk, passed out, and wasn't able to help the individual. So there's a lot of stressors with suboptimal living situations. And again, there are communities where spinal cord injury centers, like we have this luxury of having TRI, and in Hamilton there's a rehab center. So we've got them all over Southern Ontario, but they're not necessarily available north of Highway 7. So we have to worry about that. So now I'm going to get into the smoking, and this is going to be a lecture. This is the lecture component, and this is how scary smoking is, and this is why we go after people that smoke. So nicotine, we already know is highly addictive, but it's a vasoconstrictor. So if you think of before the previous slides, I talked about that people with spinal cord injuries already have problems with oxygenation of their tissue. So if we're going to put more vasoconstriction on these blood vessels, there's going to be problem. And so this results in tissue ischemia and impaired healing of the tissue. And we have carbon monoxide. So carbon monoxide competitively binds to the red blood cells that are supposed to be carrying oxygen. So when you smoke and you get that head buzz. Has anyone ever had that head buzz before? I've smoked before. I have 2 cigarettes and I feel like I'm going to fall over. And that's because my body's not used to inhaling carbon monoxide, and I'm dizzy because, well, I'm dizzy in general, but I get more dizzy because the oxygen to my brain has been cut in half from that cigarette. And so it's really a good deterrent for me. Every so often I'll have 1 cigarette and then I don't smoke again for 2 years because I remember that it's a bad thing. And then we have that happening, and then we also have this lovely toxin in the cigarettes called hydrogen cyanide, and we all know that cyanide is bad. It kills people, but we continue to smoke these cigarettes that have this product in it. And cigarettes have way more toxins in it than I'm going to talk about today. But what I want to tell you about, and which is not on this slide deck, I found a trial. So this really proves to you how important stopping smoking is from a surgical perspective. This group did a study on 120 patients, and in the intervention group, they counseled people and they gave them nicotine replacement therapy and either smoking cessation or at least 50% smoking reduction was the goal. And in the and then they operated on people and they looked at the complication rates. So in the intervention group, where we got people to stop smoking 6 to 8 weeks before their surgery, the complication rate was 18% in the smoking intervention group and 52% in the controls. So if you keep smoking, you are buying yourself trouble. And so that's why I go after people that are smoking, and I'm really aggressive with that. It's pretty mean, but it is, the facts are the facts in terms of problems. And then we have other problems too in terms of psychosocial issues. A lot of people are afraid, they don't want to deal with the problems, complacency, procrastination, denial, depression, and fear. These are all different problems that we all face, but compounding that with a spinal cord injury, especially when pressure ulcers are developing, can be a real problem. So what are some of the interventions for pressure ulcer prevention and treatment? I am going to talk to you about bed rest. So in the past, we'd say to people, you've got to go to bed, you've got to get off the ulcer, you have to you know, if you sit on the ulcer, it's going to get worse. And that's good in theory because it kind of makes intuitive sense. But if you've ever been sick before, who's been sick for a week in bed before? Anyone been really, really sick? What does it feel like to be in bed for a week? It feels pretty rotten. You look up at the ceiling, you become depressed, you get paranoid, all these things happen. Well, that's what happens to me. And you're watching the Food Channel and you're seeing repeat after repeat after repeat of these things, and you start to go stir crazy. So that's what happens when we confine people to bed. Bed rest, though, has other deleterious effects. It stagnates wound healing. It causes calciuremia, and it can cause osteoporosis, and it also increases this glycosaminoglycan, that's GAG, 4 times more than people that don't get put on bed rest. And that actually, in the wound healing cascade, can cause impairment in wound healing. And it also impairs our perfusion. So bed rest is a bad thing. And so we've stopped telling people that they need to go into bed for long periods of time. We just want you to have frequent breaks, but not to be confined to bed. And then, so my area of interest and expertise is surgery as an option. And so what I want to tell you about is some studies that have been done, and one was done at St. Michael's, and I'll just tell you about how we approach surgery. So this particular study was done, and they looked at the complication rates, and so they have basically said surgery is dangerous for pressure ulcer management because the complication rates in this study were 27%. So you got almost a 1 in 3 chance of having a bigger problem than what you started with. But what they did was they profiled people that were at risk of having the complication. And what they found in this analysis was that people that were malnourished and people with poorly controlled diabetes, the younger you were, the location of the wound over the ischium, and previous operative failure of the same site, those were all risk factors for complications in that population. This was done in the US, and so what I can't comment on is whether or not that we would repeat that same study and get the same kind of outcomes in the population. And I just want to tell you about our 10-year experience with flap selection at St. Michael's Hospital. We've enjoyed actually really good outcomes, and our complication rates are actually quite a bit lower than in the literature. So rah, we're so great, right? No. And it's not because perhaps what our surgeons are saying is our technique is just awesome, and we do a really good job with our surgical flaps. But I think it's probably a little bit more than that. I think that it's our comprehensive approach and our relationship with the Toronto Rehab Institute that helps patients to get better once the operation is done. And so this is our approach. So we do partner with TRI. We try to partner with other organizations, but it's really hard when you're from different cities. They like to work with their own surgeons, etc. We assess you for risk factors. So there I am, smoking, alcohol, and other wonderful drugs. I will go after you for this. I will hammer away at it, and we will not operate unless we get that lifestyle under control. We look for other comorbidities. We look for abnormal blood work, and we try to correct that. We get an x-ray. We look at your nutritional status, and we really go after the wheelchair and the seating to make sure that it's absolutely perfect before the operation happens. And so we have, if anyone's been to our organization, you don't just walk in or wheel in, get your surgery date, and it's all great. We have problems with getting rehab beds at this time, so we really need to advocate for more beds so that you can recover well from the surgery. And again, we get after all of these lifestyle issues, and if there's a bone or tissue infection, then we have to deal with that first. So there's lots of things that need to be corrected first before we move on to surgery. And so this is, again, a really graphic and nasty picture, but if you think that the one in the bottom left-hand corner is a big problem, that's what the surgery entails, taking a really big section of skin and tissue, cutting out the ulcer, and then moving it around. So you can imagine that all being sewn up, and if that fails, you end up with a wound not this big, but a wound that's this big. So we don't want that to happen. We know that it's a bad thing, and we want that excellent outcome that's in the top right-hand corner versus the complications that can happen. So we really, really try to select our patients carefully. And so these are the steps to success that we have found to work. And so my research is going to be on looking at all of these steps and trying to come up with a patient profile that gives us the best opportunity for successful operations for this population. This is a 2009 systematic review, but what you need to do is stay tuned, because the Canadian pressure ulcer guidelines are going to be published very soon for spinal cord injured individuals. So we've got lots of guidelines for pressure ulcer prevention, but they're not related to spinal cord injury. There's a lot of uniqueness that we have to pay attention to with that. So they're there, and I will flip through them really quickly here and let you review them on your own, and I will start my examination at the end of this session. So I'll be passing the test around. Anyways, this is my summary slide. Pressure ulcers are common in persons with spinal cord injury. There is evidence for many different treatment options, and what's really important from our perspective surgically is that your own health behaviors such as nutrition, smoking, and your ongoing relationship with a rehab center is critical for success if you do develop a problem. But really our goal is to try to help to prevent these evil wounds from happening in the first place. These are the research priorities of the Ontario Neurotrauma Foundation, of which now I'm a member. I hope that I have the opportunity to go into this race at some point in the future, and thanks very much for your time.